Welcome, conference delegates, and it's a real privilege to join you here live from London, where the sun is setting. I can see that people are gradually coming into the room, so I'm gonna just say a few hellos and welcomes at the moment before I get going. It's just great to be here. I've managed to listen to some of the presentations so far, really enjoyed the one about leadership and so on so far, but also commend you and say, wow, and congratulations for, running this meeting. So I'm Irene Higginson. I'm a professor of palliative care and policy at King's College London, which is in the centre of London. And I founded and am the founding professor of the Cicely Saunders Institute, which is the world's first institute of palliative care. And for a number of years, passionate about the issues that were faced by people with neurological conditions, we launched a program of work looking at the needs of people in palliative care with neurological conditions. And that is going to be the focus of my presentation today. So welcome to London. The sun is setting here. It's late autumn afternoon. The leaves are falling off the trees, and the view that you can see behind me is the roof view of the Cicely Saunders Institute across London. So I'm going to start screen sharing, and I'll talk through my talk, and then I'll be really happy to have questions. So hopefully people can see that all right, and I'll expect that the individuals in the room will give me a shout if they can't. And there's no shouts that I can see at the moment. So I'm going to put it on to slideshow. And hopefully that's showing as slideshow. Good, I can see a message saying it's all good. So I was asked to talk about the evidence for the effectiveness of personalized palliative care in improving the quality of life for people with neurological conditions. And this builds on a program of work that we had conducted in the UK, trying to look at this. Why? So neurological conditions are the leading cause of disability and the second leading cause of death. And yet people with long-term neurological conditions, as this conference has already shown, have multiple symptoms. And our research had, through the program of work that we'd already started on neurological conditions, shows that on average they had 11 symptoms, and many were as severe as people with cancer had. And yet palliative care tended to be focused primarily on cancer. People living with advanced neurological conditions have poorer quality of life. We knew that from other research. And also caregivers often experience high burden and distress. And palliative care has benefit in cancer, but yet doesn't seem to have evidence in non-malignant conditions, in particular long-term neurological conditions. So based on that, we searched the literature in more detail and found that there had been 3 studies of palliative care in neurological conditions. The first was one that we did in 2011, which was looking at people with multiple sclerosis. And here there was an intervention of short-term integrated palliative care, which looked at outcomes such as symptoms and caregiver burden. So the POS is the palliative care outcome scale, and the Zarit burden interview for a period of 12 weeks. And we found an improvement in symptoms and a reduction in caregiver burden. There was work by Veronese and Solari as well, looking at specialist and home-based palliative care, again compared with usual care, and finding some improvements in quality of life or some shifts in symptoms and problems. So we decided to launch a much larger trial, which we called OptCare Neuro, which was supported by the UK National Institutes of Health Research, Health Services and Research Programme. And I will say that the UK National Institutes of Health Research has revolutionized the funding and support for research in the UK. First of all, because it pays hospitals and other services to take part in studies if they recruit patients, and also bearing in mind your previous talk about leadership and leadership development, they hold and run leadership programs which people can apply to join. And I benefited greatly from one of those leadership programs where they bring together academics from all sorts of different disciplines, and you go through huge amounts of coaching and discussions and so on. The study period for this study was long. It was a 5-year period. We knew that it would take time to set up, to model everything, to recruit patients. And the aim really was to evaluate the clinical and cost effectiveness of short-term integrated palliative care to optimize care for people with long-term neurological conditions. And I should make a disclaimer, although the National Institutes of Health Research funded the core of this research, the views here are of my own and not those of NIHR. The study had a mixed method design. It combined quantitative methods with qualitative methods and mapping, a survey, and integrated aspects. I'll talk first about the mapping. Whenever you run a trial, it's very important not only to understand your intervention, but to understand the control group. And that's particularly important when you run a multi-center trial where the delivery of services may vary across your different centers. So we did some mapping to try and understand, first of all, given that our intervention was about integrated neurological and palliative care, how integrated were services and who were they looking after at the moment. We did this across the UK, so a little map of the UK, primarily in England and Wales, as you can see there, with a distribution not only in the south and London, where there's a large bulk of the population, but also in parts of the northwest, the northeast, and in the Midlands. And we collected information on the types of services that were currently available, how they were staffed, how things were integrated, and whether and what information could be collected. And we surveyed both neurology and palliative care teams because we wanted the views of both, even if they weren't connected. So our centers varied in catchment size and population covered. The neurology services varied in the number and types of clinics that were provided, and the palliative care services varied in the settings in which they worked, so home, hospitals, etc. And we saw a difference across diseases. So for motor neurone disease, or ALS as you may call it, there was most integration. And there was least integration for multiple sclerosis, and the other diseases were somewhat in the middle. And the number of neurology patients per annum receiving palliative care reflected those differences. So for example, you saw quite a few in motor neurone disease, although again, it varied enormously between our centers, and very little for multiple sclerosis. And we wanted to understand from professionals who we surveyed, following on from the initial mapping, we surveyed professionals to try and explore their expectations and views of what an integrated service might look like, what they thought about the levels of collaboration between specialties, And we sent these to our participating trial sites, and we got a good number of responses. And we've published this in the paper that's here. And I provided a few papers in the background material for the conference, but these all are referenced there. So the current levels of collaboration between the two specialties were seen differently depending on neurology and palliative care. So palliative care people were a bit more optimistic. They felt that, or a greater proportion of them felt that there was stronger links. And so they reported good, in a much higher proportion, good or excellent was 58% of the palliative care professionals, but only 36% of the neurology responses. And I think that was kind of interesting for us. And unexpectedly, everybody felt that the links were stronger in ALS or motor neuron disease. So it's very interesting, and I'd love your views. We reflect on this in the paper as to why palliative care was more optimistic that there was integration compared to neurology. The barriers that people saw and the expectations that people had for the new service were interesting. The neurology folk felt that there were some issues about resources, clinician awareness, and so on. And the expectations of the service, so what they wanted to see was greater advice and collaborative working, and better support in the community for patients and families. The palliative care team saw expectations of the new service in some ways in similar ways. So some of the barriers were similar, time pressures and resources. The intervention was short term. So some of them were worried about what would happen about longer term follow-up. But there was also a greater consideration in the palliative care responses about the issues of building relationships and dispelling myths of palliative care, but saw it as a great opportunity for symptom assessment and early introduction of palliative care, and help people think early on while they could about their likely future wishes. Now, the main report is published in a large detailed report, which is how IHR often ask us to report major studies now, which is in their own journal, the Health Services and Delivery Research Journal. And I've given you the link here to the abstract, but you can also read the whole report there. So I'll come on to some more about what we designed in the intervention now and the trial results. All of the mapping results are in the report that I've just shown you the link for, as are the trial results I'm going to be showing you now. So what we tried to do in our intervention of short-term integrated palliative care was to try and offer a service to patients who were highly complex, at risk of hospital admission, and yet not actively dying. And we evaluated that service using a fast track, pragmatic mixed method design. Now, fast track, or what some people would call waitlist designs, are well known, particularly to the rehabilitation, but also to the neurological field, slightly less well known for palliative care. But the issue is that everybody is able to receive the intervention, but one group receive it early. And it was the patient and family involvement that said we should call it fast track. And the other group are offered it later. And the idea is that you find a difference between the two study arms before the group receiving it later are offered the intervention. The reason why we went for the phrase fast track rather than waitlist is because the patient said to us, well, this service is not normally available. So even getting it at all after 12 weeks would be some kind of standard. And that's about what we have to usually wait for things. So getting something earlier, we felt fast track, a bit like fast lanes at airports, something we're becoming now a bit more familiar with, would work. So the intervention took place over about 6 to 8 weeks. the service initially phoned patients and did a face-to-face contact. Then there was a first comprehensive assessment, and then a second comprehensive assessment and review of action plans. And then towards the end of the 6 to 8 week period, there was a final review, liaison and discharge plan, with a very small percentage, as we expected, based on our study in people with multiple sclerosis that would need ongoing palliative care. We included, so our inclusion criteria were that people would have one of the following conditions, so either multiple sclerosis with an EDSS showing a level of disability, a Parkinson's plus with Hone and Yaw stages 3 to 5, or motor neurone disease any stage because of the trajectory there, and this was important, have at least 2 unresolved problems, of which one was a symptom, and one other which could be a symptom or could be psychological. So the idea would be that we wouldn't take people who only had one straightforward symptom, but more complicated illness. We included anybody who was excluded, anybody who was currently in palliative care or who'd received it within the last 6 months, or unfortunately were not in the catchment area for the palliative care services and so couldn't be visited. And the catchment area for neurology and palliative care services did differ, so that made it slightly more complicated, but we managed it. In terms of our outcome measures, our primary outcome was the changes in the combined score of 8 key symptoms as measured by the Integrated Palliative Care Outcome Scale, neurological version at 12 weeks. So between time baseline and 12 weeks. And these are the symptoms that were included in that. And secondary outcomes, of which there were 11, as well as adverse events, were pain-related and patient-related symptoms and problems, caregiver issues, and aspects of hospital admissions, and so on. And we measured receipt of services in order to understand the potential cost differences between the 2 groups. So how did the trial go? So we assessed 535 people for eligibility, and we randomized 350. Main reasons for loss was some were excluded because they didn't meet the inclusion criteria. Some people declined the study. Some people had other reasons that they didn't want to complete questionnaires, or they were about to go away, or whatever. We allocated in our randomization as planned, and we had reasonably good follow-up. And we used a multiple imputation approach to impute the findings for anyone who was lost to follow-up for a variety of reasons. But as you can see, we had quite good data capture with a limited number of deaths in both arms to the study. Most people did receive the intervention as planned, and so on. So we had a fairly good follow-up in the study. So let me tell you a little bit about the people that were included in the study. Their demographic and clinical characteristics were nicely balanced between the study arms. We had, you can see here in the columns, all participants, and then those that received the intervention, the SIPC, and those that had the standard care with the delay offer of the intervention. And we were very pleased that in a way our trial worked. We didn't have a lot of problems of people kind of evading or contamination or so on. And they were roughly equally grouped, around half men and women, similar distribution of the other characteristics. And you can see a little bit more here about the mix of diagnoses that we had. So we had quite a lot of people with multiple sclerosis or idiopathic Parkinson's disease, a number of people with MSA, PSP, and a smaller number of people with motor neurone disease. Quite a lot of people for motor neurone disease were didn't meet our eligibility criteria because they had already had some contact with palliative care. A fairly good range of time since diagnosis. Quite a lot of people, about 3/4, almost 3/4, had comorbidities. And we had a very elegant process, which was approved by ethics, about being able to offer the study to people who were not able to consent because of lack of capacity. And I'll be very happy to discuss this greater in the chat. But one of the things that we felt was very important in this study was to be able to offer the trial to people who may have fluctuating or lack capacity. So therefore, we had people who, where there was a personal consultee assent rather than direct patient consent for the trial. And we followed a very clear protocol for this. And our grounds for doing this were that if you exclude the people who have fluctuating capacity or poor capacity from a trial such as this, you're perhaps excluding the people who might most importantly benefit from palliative care because they're often quite sick. So we felt it was important to be able to offer this to them, and yet you need data around them. So working very closely with our patient and family advisory group, we developed very careful procedures for this. You can see here that we had a range of disabilities, but most of the people, required considerable assistance or more in our study. So what did we find? So what was interesting in our finding is, and what you can see here is the mean change scores, and in the table above the mean scores of our primary outcome during the study. And I'm showing you here the primary outcome. So both groups improved during the course of the study, and the palliative care group clearly improved more than the standard care group. But the palliative care group improved for its primary outcome significantly compared to baseline, whereas the standard care group did not improve significantly compared to baseline. But when you compared the palliative care and the standard care group, you did not find a difference between the two groups in the change score. In the economic findings, so what we did here was we mapped two things: quality adjusted life years, in this instance calculated using the EQ5D to calculate change in quality adjusted life year, versus difference in health and social care costs between the study arms. And this was based on patient and family reported service use, including the use of the palliative care service. And the other outcome that we've looked at, the difference in costs, is symptom management. So a difference in the outcome measure, the IPOS scale, which you can see here, hopefully, and we just reverse the scale so that there's normally a change in the IPOS, and a negative score would be an improvement. We just reverse the scale so you could read it more clearly. So an increase in score represents an improvement here. These are called cost effectiveness planes, and in essence, in a cost effectiveness plane, you have 4 quadrants, and the bottom right-hand quadrant is where you see an improvement in the outcome at a lower cost, and the top left quadrant is where you see a deterioration in outcome at higher cost. So what you hope is that most of your results in the cost effectiveness plane are in the lower right quadrant as you look at it, and indeed we found that. If you find things that are in the lower left quadrant, it means that it's lower cost, but actually the health outcomes are a bit worse. And if you're in the top right quadrant, then it shows that your costs are a bit more, but the health outcomes are better. So ideally, what you want is the bottom right quadrant, which is a cost saving and a healthcare improvement. But equally, anything other than the top left is often quite an interesting outcome. And often what we see when we see cost for quality is things that are in the top right quadrant. We also, in our qualitative work, jumping ahead, had the qualitative findings. So we did interviews in 3 of the centers that took part in our study, mostly with people with MS, or just over half with MS. Many had been with their condition for a long time. And we also conducted focus groups with staff in all of the sites to try and understand how the service worked. So let me just talk you through a few of the qualitative results before I pull all this together. So we identified some themes in what the service did, because I think it's very important in these sorts of interventions to know what the service was doing. So there were 3 key themes shown here that came out of this. One was about helping people adapt to losses and build resilience. So this one is about how the person said to the palliative care nurse, you know, it's great to have a reassurance that actually it's normal that I feel this way. Paying attention to the function deficits and maintaining stability was also about helping somebody with pointers about what I can do, how I can feel a bit better, get more sleep, manage my illness better. And importantly, because in palliative care, as we know, the patient and the family is part of the unit of care, enabling carers to help and care. Somebody say, actually, you're probably right. You know, because as a carer, you don't have a handbook and you don't know what to do. There were these 3 overarching themes then, as I've shown you here, and the outcomes were often quite subtle, softer things. So things that are difficult to pick up in the standard outcomes that we would tend to use in a trial such as this. And there was a lot of value being placed on holistic assessment and being listened to, being heard by the short-term integrated palliative care. And caregivers being able to talk to someone and reassured they were doing a job. And there were some challenges that staff identified, particularly around gaps in integrated working. So let me try and bring it all together for you in kind of the conclusions, next steps, and future work. And then I'd be very happy to have an introduction. So I think this is the largest trial of palliative care in people with a variety of long-term neurological conditions who were severely affected. And although there was no significant between group differences on our primary outcome, the data do demonstrate that the short-term integrated palliative care provides improvements in physical symptoms and quality of life at a lower cost and with no harmful effects when compared to standard care. So where do we feel that this takes us? So I think that it takes us in a good direction. Obviously, it's not a massively positive trial, but then our outcomes are complex in this situation. But it is a positive trial in that it shows a benefit and at a healthcare cost saving, something which healthcare is increasingly concerned about. However, I do think that probably some further work is needed to think through and further refine the way in which short-term integrated palliative care and holistic palliative care approaches are developed for this group, with a particular focus maybe on better integration of existing services and specialties, and maybe a greater integration on what some of the elements of what palliative care does could be turned into self-help for patients and families. So I think there's some work to be done on optimizing the short-term integrated palliative care and probably standardizing it, doing a little bit more on the referral criteria and the outcome measures, and then understanding more about the long-term effects of an intervention such as this. Obviously, we have data over the 12 weeks of our study, but we don't know the longer-term effects or whether there was any impact more towards the end of life in these patients. And I'd just like to end by saying thank you, and to give you some of the key references that give you the references to all the other things on this work. So the main, one of the main papers that came out in neurology, and then really the main report, which gathers all of the key papers together and considers the findings in depth as a sort of book and manual, because it has the full details of the intervention and more or less everything else you could possibly wish to know about the study. So thank you very much indeed for your attention. And I'd just like to also thank the National Institutes of Health Research in the UK for having the foresight to fund this research. Thank you for your attention.
Thank you very much, Dr. Higginson. And just to briefly introduce myself as a new face here, my name is Chris Tiroli, and I am a member of the meeting planning committee for the IMPCS. I just want to say again, thank you so much for that outstanding talk. I think this work is such an inspiration, and I think where many of us feel and hope the world of neuropalliative care is going. There's a few questions filtering in the chat and Q&A, and I have a few questions also. I think one of the questions that some of the audience members are asking is, you know, as you think about, right, logically we can make sense, palliative care improves quality of life, and yet when we measure these outcomes in some of these trials, sometimes we're just not able to capture exactly what is being improved. And yesterday, Benzie talked a little bit about our outcomes in palliative care and whether just reducing the negative is sufficient, or if we can actually think about how to improve the positive, how to measure how our patients are living and thriving. And so I was hoping you could talk a little bit again about sort of your thoughts on why there might have been some limitations in finding that statistical significance in the outcomes, and then as you think about broadening this in the future, how we can start to measure things that are most important for our patients.
Well, it's a big question. And it is probably going to keep us all in a lot of work for many years. I do think that reducing the negative is important because people suffer, and and in a way the slight difficulty of only focusing on improving the positive is the sell to policymakers. Because if we say, well, you know, people said that they had a lot of dignity and they had this, so I think those things are good as secondary outcomes. And I would say that it's not that there weren't significant differences in things. There were significant differences in things, but the problem was that the primary outcome wasn't showing the shift. But it is interesting. And, you know, I think the answer is slightly different, actually. I think the answer is that we should move away from a complete reliance on a single outcome from a trial with statistical significance. And we talk quite a lot about this in the neurology paper. And there's been a big move. If you read a number of papers that have been published in Nature, you know, statistical significance is there to help us make sure that we're not finding chance effects and to find the degree of difference greater than chance. But it shouldn't be the complete weapon of what we have, and we ought to be looking at results more in the round. So if you look at the neurology paper, we discuss this a lot in the discussion. What does it really mean, a statistical significance or not, when you can see that one group, that both groups improve at a time when you'd be expecting them to be deteriorating, and one group expects more than the other. Because your other problem is that if you run any study, you'll probably be improving the control group as well, just for the fact that you're mentioning the words to them and you've got somebody going in monitoring them, which doesn't normally happen. So I kind of think that, yes, we need better outcomes, but we also need designs that are, and I think we were right to take a broader look. So the cost data is very compelling. I mean, here we have lower costs and better health outcomes in 74%, 84%, according to cost effectiveness planes. That's very good. Most people talk about, in the UK, they talk about QALYs, you know, cost for QALY. Here, we've got a cost saving for a QALY. Do you know what I mean? I mean, it's, you know, we really ought to be using that. Then you can also see the qualitative data and you can see the lack of adverse events. So taken in the round, I would say, is the more important thing to think of than endlessly pursuing single outcomes. And the risk too much would be to focus on very, very minute outcomes and so on. So the results are what they are. We've reported them as honestly and as straightforwardly as we can.
Thank you. I think that highlights the point that maybe we need to, as we think about pushing this field of neuropalliative care forward, maybe we need to think about less traditional outcomes or less traditional metrics for what is a positive outcome in our studies. I think so much comes out of the qualitative data that you got from this study that is often minimized as we look at these results, and I think you really highlighted how important that is. Some of the audience and myself as well were interested in the inclusion criteria for this study, which were, it seems like, fairly broad. You wanted to include a broad swath of patient populations and as well as symptoms. And so just wondering if you found anything in looking at the data of, you know, you really felt like the intervention was most effective, or where you feel like there were specific symptoms or patient populations where there were differences or more effect of the intervention compared to others?
Yes, I think if I kind of had my time again, I'm not sure I would do all the diseases all together. We were responding to a specific call about neurological conditions, I think, when we started it. So we sort of felt, and that's why the word long-term neurological conditions comes up so much. So because we were responding, as one often does when one wants a grant to do the study one would like to do, to a specific call from NIHR. And NIHR is not a disease-focused funding. Now, that's brilliant for palliative care because, you know, let's face it, when you go to the single neurology charities, their interest is in beating the disease, and they fund a lot of research into that, and they're not really very often very interested in funding palliative care, although the MS Society did fund our initial small study. If you go to the cancer charities, that's certainly a challenge. So in some ways, NIHR is very good for palliative care because it doesn't focus on single diseases. But the challenge is that it then often wants you to put diseases together because it's interested in whether an intervention will work across a number of different diseases. So I think one of my first criticisms is, should we have put all the diseases together, or should we have thought more about the differences between the diseases, maybe left motor neurone disease out completely because it's a very tricky group to include or at all, and focus more on either MS or Parkinson's patients. And even then, there are some challenges and differences. So that is one thing I would have done differently. The second thing is the very broad inclusion criteria around a symptom and one other problem. We wanted to make it easy for clinicians to be able to put people into the study and for people to be able to get into the study. But arguably, that may have meant that we kind of didn't really focus enough on the people who would benefit most from palliative care, i.e. the most ill. And also we were trying to, because we wanted the follow-up data at 12 weeks in the outcome, we were trying to avoid people who would die very, very quickly. So I think that was the other challenge. And I think probably if we'd been in one disease, it would have been easier to kind of hone it down more specifically on the problems. So I think those are two things that I'd certainly be thinking about doing differently were I doing it again. I'm not planning
Great.
to right now, though.
And so some of the other audience members were asking about sort of giving a little bit more definition. You mentioned actually at the end in the qualitative outcomes, sort of what the patient and care partner perspective was on what the palliative care team was doing. I guess my question is, was there any specific training, or what was the charge of the palliative care team that was integrated either in that fast track group or in the standard care group, and if there was differences in kind of the charge that they were given? Or I noticed the word pragmatic was in the design, so I don't know if this was just standard of what the palliative care providers would do in that setting.
Okay, so so the word pragmatic for the trial is the specific use of the word as a pragmatic trial, in that it operates in the real world, rather than in very, very controlled conditions. But we certainly did train, and we took palliative care services that were interested in offering neurological services. We didn't take palliative care services into the study that weren't interested in offering neurological services, and we worked quite closely with them. And we also took settings where the neurologists themselves were also willing and interested, although to greater or lesser degrees in some of the areas in terms of our recruitment and referrals and so on. So so that was a kind of key element. So there certainly was an interest, and we had a clinical group running during the study. So we had two groups that kind of ran in parallel. We had a clinical group and clinical leads, and we had standard operating procedures for what the service did. So the palliative care service, and you can see that in the big report, had a standard operating procedure and symptom guidance and manuals, and actually recorded standard information on the patients that they saw. So we were able to understand what they did. And in the main report, we actually have a detailed analysis of that. So you can actually see the detail of what the services did on the ground, how often they saw people and what they did. And there certainly was some dose variation in what the services did in the different areas, which is something that one needs to think about. So that's a section and a whole chapter in the big report that we looked at. And I think that helped us because, and we trained all of the services in a kind of assessment and the standard operating procedure of what they were doing, led by two clinicians who were in the team who had specific neuropalliative expertise and interest. And they trained and supported others. And then the clinical sort of service team met throughout the project across the sites using telephone meetings, basically, and online meetings like this to discuss and agree sort of any issues or challenges that they had. In terms of the randomization, we had to be quite careful with this. But we did manage it. It needed quite a lot of thought because we were using a single blinded design. So the research nurses didn't know which arm patients were in when they went to the study. So the way it worked is that the research nurses went and recruited people and did the baseline interview. And then what happened is that that went to a central randomization service run by the Registered Clinical Trials Unit that oversaw all the procedures. So we did everything properly. And they issued a random number that went to the trial coordinator. And the trial coordinator contacted all the patients individually to tell them that a palliative care service would be in touch and when, okay? And then, so that they didn't sort of sit there for 12 weeks wondering whether somebody would be in touch or not if they were in the control arm, and they didn't think, why is this person ringing me, if they were in the intervention arm. So the coordinator contacted them to let them know when the palliative care service would likely be in touch, and to say, come back to me if they don't, and to emphasize that when the research nurses come, it would be very helpful if they don't say whether they've specifically seen the palliative care service themselves or not, except obviously they have to say what nurses have visited them at home, but we were able to include it in a vague enough way in the questions. Then what happened is that the details of the people in the fast track arm were passed immediately to the relevant palliative care service, which was separate to the research nurses, who then had the details, the name of the person, and went to contact them. And if they were in the control arm after week 3, after the third assessment, sorry, at 12 weeks after the third interview, then after that third interview, data collection was done and they were at 12 weeks, then they were also then passed to the palliative care team to contact them. So operationally, it was quite a procedure to manage, but we managed it.
Excellent. Well, I only have one more question. If anybody else has other questions, I know we still have about 15 minutes left here, so feel free to keep populating those into the chat. I actually wanted to circle back to those, the cost-effective outcomes. And you know, I feel like when we talk about palliative care, that is one of the areas that people actually get very nervous about, right? In implementation initially, I think that we can meet resistance of these integrated programs from leadership potentially in how is this going to be cost effective? How does this translate? Why is this actually beneficial for the organization? And so I was just hoping you could talk a little bit more, if you have any more information or thoughts on those outcomes that, you know, folks could theoretically be using as we think about advocating and actually translation of something like this again into clinical practice elsewhere.
Yeah, so the health economists in the study helped us very much with this, and I think it is something that I think quite a lot about, and it's something we've done a similar program of work looking at breathlessness with the next step on the breathlessness work, and it's making me think that maybe we should do that with this project too. There is a number of economic approaches that you can take in looking at palliative care services. And I'd really encourage you to look at the work of Charles Normand and Peter May, who have done a huge amount of work just simply quite often using routine data on hospitalizations, using US data. In the US, you because of claiming, you can collect more data about cost to the healthcare system. Now, in this study, we took what's called the societal approach to costs, which means that we collected essentially 3 sets of data. We collected data about healthcare use and social care use, so formal care costs. And we also collected data about voluntary care costs and voluntary care use. And we also collected data on what patients and caregivers did. So that is a societal approach to healthcare costs. The data in the cost effectiveness planes is the costs to formal healthcare services and social care services, and doesn't include the caregiver costs. But if you just include the caregiver costs as well, you see the same result. So that's good in a way, because this intervention is not transferring costs from healthcare to informal carers, which is what you also want to avoid if you can. The second thing to say about the costing in this study is that it was based on the reports of patients and families. Only by getting the reports from patients and families on the healthcare services that they've used and their own healthcare costs can you really take a societal approach to costings. But it is quite a labor-intensive way to do it, because there's quite a long questionnaire that they have to complete, which tells you all about the costs, the services that they've used. Then the approach that you use, and it's easier to do it in a national study than a multinational study, let me tell you, having done multinational studies doing this, is that then you apply to individual items of healthcare a standard costing framework. And in the UK, these costing frameworks have been developed. So an hour of a specialist nurse costs X, basically. And there is that health economists in the UK use a standard costing framework that's updated every year. And basically you take the time that people spend on different interventions or in hospital or whatever, or home visits, and multiply that by the standard unit costs of that. And that gives you a cost, okay? So that's a very straightforward way of doing the costing analysis. Then that gives you cost data. Now, a proper health economist would say that you can't look at only cost data, you should look at outcomes as well. Hence the cost effectiveness planes. So you then contrast one thing against another. What's the health outcome change versus what's the cost effectiveness change? And interestingly, actually, although I'm very, very critical of the EQ5D, which is the standard measure that all health economists use because it's a crude scale of 5 points, which looks at disability and pain, etc. Actually, it showed a degree of improvement that showed that despite it being a very crude outcome, actually wasn't so bad. Because as you can see in the data, you see a degree of improvement along with a healthcare saving. And the degree of improvement is not that dissimilar to the degree of improvement that you see in the symptoms. So that's that approach to costing. There's two other approaches that are worth thinking about. One is called discrete choice experiment, which is a preference system where people choose elements of a service to see which are most important. And that might be good to do with an intervention like this. And in the work that we've done with breathlessness support services, we just submitted the papers that we've done on that. And that's quite helpful in refining a service. And then the other approach that you can take is Markov modeling, where you actually model the costs if this intervention were produced on a societal basis. And again, we've done that further research with the breathlessness work to show that actually, and you use systematic review data and other things. So if anybody's up for it, I'd be very interested in going down the line of doing almost what I would see as the next stage after this study, if we really want to look at the costs for policymakers, which would be doing discrete choice experiment, about taking the elements of the service and seeing which are most valued. And it's almost like you go to a discrete choice experiment, you go to a restaurant and you've got two set menus, okay? You can choose menu X or menu Y, but you can't have bits of both. So in discrete choice experiment, you have that, but it forces people to trade what they really matters to them, one thing versus another thing. And so quite quickly you can find out. So it's an interesting technique that is something that health economists have introduced me to, which I find very interesting and exciting. And for me, I used it first in daycare. And we discovered that actually people didn't value the hairdressing as much as everybody thought. And what they really liked to do was to see a therapist and a doctor.
Great. This is absolutely outstanding work. I think we just have time for one more question, and actually Benzie just put one into the chat. And so, you know, this question really gets at how and when we're integrating these palliative care interventions, and talks about the role for actually pushing it even earlier, taking it out of the hands, at least, you know, this eventual referral to a specialist, but actually doing what has been referred to as primary palliative care or neurologist-provided palliative care. And how do you feel like we could potentially integrate those so that we could potentially intervene earlier for many of our patients?
Yeah, I think this is a way to go. And also to think about how much of these interventions, particularly now we're in a slightly different world post-COVID, aren't we? With interventions like this, you know, I'm here in London with the sun setting, you're there with the sun rising, we think, or midday or whatever you are, yeah, midday. So I do think that we could think much more creatively about how we would introduce things that are much more self-help. So I suppose my direction of travel would almost be, what could we put into primary care that would help patients identify when they've got needs, ask for things, and use these sorts of interventions as a sort of primary palliative care for neurology in those patients, and integrate it earlier on. And I honestly think this is where the populations are going. So I think it's a great question, and I think the direction of travel is right. The challenge then is about designing the studies to assess it. But hey, that's the fun thing of designing studies. You never get it right, and you can always do a better one next time.
Great. I think with that, our time is just about up. So again, Dr. Higginson, I really want to say thank you so much for talking with all of us today. This is an absolutely outstanding study, really inspiring work. I think makes many of us think about how we can be doing similar work and thinking not only in the world of research, but also translating this into the care to improve the lives of our patients. And so I just want to say thank you so much for your time today.
Thank you very much, and best wishes from London.